Welcome back. I'm Army Pikett, and this is Blood Gas of the Week, case number 6. Let's jump right in. A 4-year-old female spayed terrier mix is presented with a 3-day history of vomiting, lethargy, anorexia, and weakness. The owners tell you that she is a master toy destroyer, and occasionally she likes to eat pieces of those toys. At presentation, she's weak but ambulatory, has depressed mentation, and is bradycardic at 50 beats per minute. Her femoral pulses are there when you feel for them, but you wouldn't call them strong, and her blood pressure is a little bit soft at 92 on 53. Her ECG shows the tall tinted T waves that are characteristic of hyperkalemia. The excellent veterinary technician lands an 18-gauge IV catheter in the cephalic vein on the first attempt, collects some blood for analysis, and your resuscitation efforts begin. A couple of minutes later, your stat blood results come back, so let's interpret this blood gas. As always, the first step is to determine if we have a venous or an arterial sample, and in this case, our sample is venous, so we're going to move on to the acid base. Her pH is 7.4. That's the perfect middle of the pH range. So, this means that she either has a normal acid-base status or she has a mixed acid-base disturbance. Interpreting this as normal and not looking at the metabolic and respiratory components of the blood gas is probably the single biggest mistake that people make when they read blood gas reports. A normal pH can mean two things. It can mean you have a normal blood gas, or it can mean you have a mixed disturbance. The way we figure this out is to look at the respiratory and metabolic components of the blood gas. So take a look at the PCO2. It's 40, which is a normal respiratory value. And then we look at the bicarbonate, and it's high. It's just a little bit high, but it is high, so we have a metabolic alkalosis. We already said the pH and the PCO2 are in the normal range. So because this pH is normal in the face of a metabolic alkalosis, we're going to call this a mixed acid-base disturbance. Let's look at it with the tic-tac-toe method. The pH is normal. The PCO2 is also normal, but the bicarbonate is high, so it goes over in the basic column. Next, we look at what lines up with the pH. The pH is normal, and if both the bicarbonate and the CO2 are in the normal column, then we would probably have a normal acid base. But since only the PCO2 is in the normal column and the bicarb is off in the basic column, we have a mixed acid-base disturbance. So, this is a mixed acid-base disturbance characterized by a mild metabolic alkalosis with a normal PCO2 and pH. To help understand the concept of a mixed acid-base disturbance, let's talk for just a minute about what's going on with this patient. The final diagnosis in this dog turned out to be a gastric foreign body and an Addisonian crisis. The dog was an undiagnosed Addisonian, and the illness from the gastric foreign body caused decompensation, and that was the point at which the dog's Addison's disease was diagnosed. If you didn't have a blood gas on this patient, it might take a couple of days to diagnose the gastric foreign body. Patients having an Addisonian crisis are often vomiting, but when they're severely compromised as this patient is, we expect to see a metabolic acidosis. This is because of the circulatory shock and the ongoing volume losses. We were looking at a cold, shocked, and very compromised patient. When we ordered the blood gas, we expected to see a significant metabolic acidosis. A metabolic alkalosis, and particularly the hypochloremic metabolic alkalosis that was identified in this patient, is most commonly caused by protracted vomiting due to a pyloric outflow obstruction from gastric foreign bodies. Other things that block the stomach acid from leaving the stomach and being reabsorbed in the GI tract, like tumors in the pylorus or tumors outside the stomach that are pinching off the pylorus and preventing the stomach from emptying, can also cause this blood gas change. Regardless, the hydrogen and chloride that are secreted by the glands in the stomach are being lost due to vomiting instead of getting reabsorbed in the intestines. Patients who are having an Addisonian crisis do vomit, but they should still be getting some of their gastric secretions through to their GI tract. You can see a low chloride in these patients, but a metabolic alkalosis in these patients who are having a crisis is pretty uncommon. It would have been very easy for someone to glance at the pH, see that it's normal, look at the electrolytes and the patient's signalment, and determine that the patient is probably having an Addisonian crisis, and treat the Addison's disease, but miss the gastric foreign body for a few days until she failed several feeding trials. Evaluating the complete blood gas and recognizing a blood gas that doesn't fit the expected profile for this disease led this great emergency doctor managing the case to recognize that this patient actually had two major problems. If you're interested in learning more about how to identify mixed metabolic disturbances or learning more about how hypochloremic metabolic alkalosis forms, check out the links on the acid base page of the website. Until next week, keep the rubber on the road and the blood inside.